Greetings, ladies and gentlemen. I wish we could have met in person in Munich, but it's still great to meet you virtually. I'm hoping that the next time will be face-to-face. My topic is today assistance systems in aspect with improving patient safety and clinical processes. I'm Gozde Inan from Turkey. I received documentation and technical support from SmartPilotView Dräger during my research, and I have no conflicts of interest to disclosure. As I said, I'm from Turkey, and Turkey is a strategically significant country that connects Asia and Europe. My home is Ankara, which is the Turkey's capital city. I work at Gozde University Faculty of Medicine, named after the great leader Gazi Mustafa Kemal Atatürk, and our hospital is one of the Turkey's biggest university hospitals. In light of Dräger's novel assistance system, SmartPilotView, I would like to take a look at whether assistance systems improve patient safety in preoperative settings. I'm going to discuss preoperative outcomes in light of our experience with SmartPilotView. Since the first anesthesia performance, patient safety was and monitoring and optimizing anesthesia management has been the major concern. The medicine, of course, benefited from technical advancements that occurred in parallel with the Industrial Revolution. The main issue in the fourth revolution we are currently in today is connectivity and artificial intelligence. Well, the main question is what waits us in the future from the point of clinical anesthesia and monitoring? Should we be concerned about robots in the future? Otherwise, how can we take advantage of technological advancements to improve patient safety and preoperative outcomes? Autonomous systems, also known as robots, have become a vital part of our lives in a variety of disciplines, including medicine, thanks to technological advancements, actually. The use of robots in anesthesia can be divided into three categories. Assistance systems, which I will discuss in this session, are examples of decision support systems, which really is a type of cognitive robots. The cognitive assistance systems combine human intelligence with information technology in a software. Are they really needed? In today's anesthesia, the anesthesia work environment is more complex with lots of data and monitors with sophisticated functions. This complexity actually can impact the maintenance of adequate anesthesia and preoperative outcomes, and so patient safety. That's also a challenge for education and training in anesthesia. Then how can assistance systems help reduce this complexity and further improve patient outcome? As you can see on the diagram, time is required to achieve a clinical benefit from data and raw information. The length of time it takes to make a decision is dependent on the amount of data, and it will take time to translate this new data to information and to clinical benefit. It will take lots of time. Actually, assistance systems reduce this time to us. With the aid of assistance systems, the flow of data and information increases, and it reduces the possibility of making mistakes while providing consistent, reliable information. As the workload reduces, productivity and efficiency and, of course, quality increases. Now, today, my topic is Dräger's novel assistance system, SmartPilotView. I will give you a quick overview of the device, explain how it works, and try to provide some clinical research findings, especially on preoperative outcomes. As you can see, we can call SmartPilotView both anesthesia information management system and right advisory system. The software monitors and calculates data for the use during the anesthesia case. It is not only a drug advisory system, which is a type of decision support system, but also logs data during anesthesia case for a retrospective analysis. The software visualizes the drug effect based on pharmacokinetic models and the drug interaction based on pharmacodynamic models. It is really smart because it visualizes the synergetic and additive drug effects on a screen in a specially developed two-dimensional pharmacodynamic diagram. Furthermore, a pharmacodynamic parameter, which we'll discuss later, NSRI, is calculated based on the synergetic drug effects. Depending on these calculations, taking into account both hypnotic and opioid interactions, it displays current anesthesia level and the expected course of anesthesia over the next 10 minutes. I guess the story, it all started with the idea of that controlling anesthesia should also be as good and easy as a flight control, such as between takeoff and landing of a plane, which is similar to our anesthesia induction and recovery. That is the preoperative period, as we call. It creates a roadmap with navigation. It has been almost 6 years since we have been using SmartPilotView. Here you can see the SmartPilotView integrated with anesthesia machine, monitor, infusion pumps in the anesthesia workstation. Let's get closer look to the system. This is the SmartPilot screen. As soon as SmartPilotView is connected to the anesthesia machine, patient monitor and compatible syringe, pumps, ventilation, and volatile or intravenous anesthetic settings and data relating to the subject characteristics are automatically integrated. The SmartPilot receives all of these data. Mainly, the screen is divided into two parts, which is left and right-hand sides. In the upper right-hand field, you can see the patient monitoring data. SmartPilotView doesn't monitor, but only reflects this data. Below the monitoring data, SmartPilotView displays and logs the intravenous and or volatile drugs administered to the patient with a time scale. The displayed interval ranges from past 30 minutes to next 20 minutes. And you can sometimes change these time intervals. In other words, you can visualize the entire anesthesia process with history, actual time point, and predicted future. The time-based display shows the dosage information and the calculated effect site concentration of each administered drug. The main mechanism of action is that calculations by pharmacodynamic and pharmacokinetic models. It consists of a section with the name of the drug, a history section, a prediction section, and a section with the current effect site concentration value. As you can see, the dosing rate or the plasma concentration of the administered drug is displayed as a gray line. The calculated effect site concentration is displayed as a colored area in the history and as a dark colored area in the prediction. The corresponding effect site concentration scale has the same color and is labeled according to the selecting drug. While suppressing the response to surgery was sufficient in the early days of anesthesia, technological advancements now allow for the use of multimodal anesthesia. Response surface models were developed to illustrate the combined clinical effects of two or more drug concentrations pharmacologically. The hypnotic and opioid concentrations are assessed on the X and Y axis respectively, and the synergistic effects of drugs known as isobols are shown on the Z axis. As a commercial product, SmartPilotView incorporated these synergistic interactions into its operating principles. The main mechanism is on that. Isoball lines in two-dimensional diagram representing areas of probability, how patient will react to a defined pain stimulus and indicating level of anesthesia. The best part is that it visualizes the 3D graphic of this complex pharmacodynamic interaction as a 2D graphic form from a bird's eye top view, similar like navigation maps. The software visualizes the synergetic and additive drugs effects on this 2D pharmacodynamic dynamic diagram, which is on the left side of the screen. It supports all kinds of general anesthesia regimes, total intravenous, volatile anesthetics, and combination of both. Patient status and surgery events can be marked also for various situations and are shown on this diagram and on the timetable. This enables individualization of patient status, actually. Drug combinations, as we all know, with the drug combinations, volatile and opioid will require a significant lower concentration level of anesthetic agents. As I said, the display area, shows 4 isoballs that represent certain levels of anesthesia depending on the settings for this diagram. The calculated level of anesthesia effect is constant on this line as shown with red targets. I mean that in the same isoball, in each isoball, the anesthetic level is constant. Noxious stimulation response index is a novel anesthetic depth index computed from the pharmacodynamic interaction model. As we already talked about, the software visualizes this synergic effect. And furthermore, a pharmacodynamic parameter, which is NSRI, is calculated based on the synergic drug effects. NSRI ranges from 100 to 0, where 100 is fully awake and close to 0 reflect very deep anesthesia. We can use NSRI to as a reference for managing general anesthesia depth. This what if feature is a very important feature for the SmartPilotView. It's just to try if I give just an anesthetic, what will happen afterwards. The what if display only takes account of the drug in question and not of any dependent drugs. It shows only the each drug's pharmacokinetic effect. After a possible manual administration of a bolus is confirmed, the subsequently calculated pharmacodynamics may deviate from the former prediction. Let's talk about the preoperative outcomes and clinical consequences. I would like to investigate preoperative outcomes in 3 topics. The first topic is depth of anesthesia. SmartPilot helps us to individualize and predictable anesthesia management. Most commonly, we use BIS to monitor the anesthetic depth. But this is accurate in determining solely the hypnotic component of anesthesia. It may not adequately reflect the even hypnotic state in some instances. For example, during induction because of artifacts, and during the recovery period, also emergence of the patient because of the artifacts. Unusual BIS readings can be observed because of inaccurate low voltage EEG analysis. Furthermore, SmartPilotView gives a priori anesthetic depth estimation. This is very important because it allows anesthetic depth to be changed or to be visualized. whereas BIS only provides posteriori information, usually after a delay in response, actually. In some cases, mostly in awake craniotomies, we performed SmartPilot Vision. We use SmartPilot Vision, and as you can see we individualized our anesthetic depth for the patients, for each patient actually, by using SmartPilot View. Less overall consumption of propofol and remifentanil, and we had better control of sleep, awake sleep periods. We had fast wake and recovery, and it decreased the electrophysiological recording affection. And here you can see in our research, this was for the spinal surgeries necessitating neuromonitoring. And as you all know, during the neuromonitoring processes, the standard or the gold maintenance of anesthesia is total intravenous anesthesia without using neuromuscular blockers. And so in case of these situations, you should deepen your anesthesia because the patient may move and during the monitoring. And then if you use overall propofol, it causes hypotension, and it also affects the neuromonitoring findings. By using by SmartPilot View guidance, we saw that we found out that intraoperative hypotension time was reduced. So SmartPilot View guided TCI improved intraoperative hemodynamics and was effective in optimizing intravenous anesthesia without influencing neuromonitoring. The second part is drug optimization. As you all see, when we compared our standard BIS guided anesthesia with the SmartPilot guided anesthesia during spinal surgeries, we saw that by enabling for precise anesthetic titration during spinal surgery, SmartPilot View was a decision support device potentially improving intraoperative decision making, and it also enabled faster recovery and reduced anesthetic consumptions. Otherwise, we also compared the same study design with the intracranial mass surgery. That was the outcomes were similar with the first study. Still, we had rapid recovery and better Aldred scores even after intracranial mass surgery. This is a recent research, and they also searched SmartPilot View guided anesthesia provided faster recovery from desflurane anesthesia. The last but not the least, it's the part of its effect on state of art of anesthesiology maintenance. Unfortunately, there is only one SmartPilot View in our clinic, and as I can say that it is more enjoyable to administer anesthesia in that operating room. The visualized administration of anesthesia not only improves our workflow efficiency, but also education and training in anesthesia. Thus, operating room is where our residents want to work most. Aside from common technological issues, certain situations may limit the usage of SmartPilot View actually. Some patients groups data are not compatible with the software because only adults data should be entered in the SmartPilot View. SmartPilot View is intended for use with the data of adults only. This limitation is in the demographic data applied as a result of the pharmacological models on which all calculations are based. Again, various patient-related disorders and diseases that may change during drug pharmacokinetics also may limit the usage of SmartPilot View. and some settings because of SmartPilot, some settings will also influence the limitations or influence the administration of anesthesia. But as far as I know, with the newest version, current version of the software, several of these setting limits are no longer an issue. Finally, SmartPilotView converts abstract device data into comprehensive visual information. So it gets easier to make decisions. And via SmartPilotView, which has proven to be beneficial in our daily practice, more optimized and individualized anesthetic titration is maintained. Thanks for taking the time to listen to me. Thank you.